Hello and welcome to another episode of the Life After Cardiac Arrest podcast with me, your host, Paul Swindell. Today I'm talking with a regular guest. It's Dr Tom Keeble, and someone I haven't had a chance to talk with for a little while because he's been getting involved heavily in the topic of the moment, which is COVID-19. Welcome, Tom, and good to hear you again.
Yeah, hi there. Thanks for inviting me.
You've been getting involved with COVID-19. You've actually been doing it as a method actor would. You've actually been experiencing the disease yourself, haven't you? So tell me all about your experience there.
Yeah, well, I certainly had a 2-week period of feeling absolutely ghastly, like nothing else I've felt before, with fevers and muscle aches and just feeling absolutely lousy, and pretty much all the classical symptoms that are described that people talk about. But at the same time, I then tested negative before I went back to, or at the time, but we know that also the test itself is only about 70% positive in truly positive patients. So rather than a very bad dose of man flu, which my colleagues take the mickey out of me for, I think I probably did have it, but I'm very lucky and glad to say that I'm out the other side and back to good health now. But I can understand why anybody who gets this badly will feel truly ghastly. And you can also imagine that if people get it that bad, if you are elderly or have other health problems, you could imagine why it would really take its toll on you, because, as I say, it's a brutal illness.
I guess you were pretty fit and healthy prior to contracting it.
Yeah, I wouldn't quite say fit, and I wouldn't quite say healthy, but I'm in relatively reasonable shape, and I don't have any other underlying health problems. But at the same time, as I say, I think this is, as we know from our politicians and others, this is an indiscriminate virus that I think we don't understand why certain individuals with no risk factors get particularly bad illnesses. I think it's an immune response that we don't fully understand.
And so you're back to full health, are you now?
Yeah, no, I'm definitely back to full health. I'm getting up with my young children in the morning, and I'm actually wanting to do something useful. And I wasn't wanting to do that for at least 2.5 weeks. So yeah, I'm in good shape.
Well, that's good to hear. And you're back to work as well, I understand?
Absolutely, yeah. No, there was a lot of illness. Obviously, there's as much illness in the medical fraternity as there is in the general population. And so we had half of our consultant workforce off last week. And so I did the wards at Southend last week looking after predominantly cardiac patients. But I had 4 patients with COVID-19 who were in the side rooms and being obviously looked after in line with all of the sort of protective guidelines and the treatment guidelines that we have.
Have your wards been just packed with COVID-19 patients? Because you see in the newspapers and the reports about how the people aren't reporting perhaps when they've had a heart attack or some other condition, and they're just not going to hospital. How's that affected your cardiac wards?
Yeah, no, our cardiac wards are about half full. So you're right that we don't fully understand this, and I'm sure we will in the passage of time. But at the moment, we're unclear as to why. So heart attacks literally across the world, this is reported in America, in Italy, and in the UK, have fallen 38% over the last month. So there's there's 2 possible explanations. Number one, for whatever reason, whether it's related to stress, whether it's related to lack of viral exposure of other pathogens, whether it's related to lack of air pollution, related to no airplanes and related to no or much less cars and travel. Maybe all of those things are what kick heart attacks off. And if you then retract all of those, then maybe that leads to less heart attacks. We don't know. The other alternative and probably complementary explanation, and these are probably happening together, is that unfortunately people are very scared at the moment. And if people get chest pain, rather than what they would normally do, which is either call 999 or go and see their GP or seek medical attention of some sort, potentially they are so petrified about going to a hospital or even worrying the NHS, for want of a better word, that they sit at home and they sit with their symptoms, and maybe they have their heart attack at home, and it's only maybe 5, 6, 7 days later when they have heart failure and problems that maybe they attend hospital, not with a heart attack, but with the complications of a heart attack. Although saying that, we haven't seen huge amounts of that, which is what we thought we would see. If people come late, we thought we'd see all the complications like we used to see over the sort of 2 or 3 decades ago. But we don't seem to be seeing that either. So I think the honest answer is the numbers are definitely down in cardiac acute medical problems. Same with stroke. But we don't fully understand. And I think only in the passage of the next few months will we get to the point where we understand what happened to these patients. And was it a truly decreasing incidence, or actually did they just come late, or did they just find their way to hospital or to medical professionals late and in a different fashion? And I think we don't know that.
Is that true for, well, I'm sure it probably is, for cases of cardiac arrest as well?
Cardiac arrest is very complicated at the moment. COVID-19 poses particular challenges to healthcare professionals if you have someone with a cardiac arrest. Because when you have to do CPR and obviously ventilate the patient and breathe for them when they have a cardiac arrest, if you're not protected, i.e. having mask, gown, gloves, goggles, hat, etc., it's if the patient has COVID-19, it's potentially an extremely risky chance of transfer of that viral load to the rescuer. And so cardiac arrest has changed a lot in hospitals for that reason. And so when we suspect that someone is COVID-19 positive, and we think there is a significant risk of the patient having a cardiac arrest, obviously at this time we're in a hospital environment, then we will don all of the protective equipment so that if the cardiac arrest does occur because the patient's very poorly, that we are completely ready to deliver CPR, intubate them as required and breathe for them and do whatever emergency therapy is needed, but that both the patient is safe and getting the right treatment, but as importantly, the staff are also getting the right protection so that they're not unnecessarily exposed to a really high dose of viral load, which, as we've seen in Italy and in the US and in the UK, can expose healthcare professionals and result, unfortunately, in their early death.
Yeah, it's a very difficult situation to be in. How do you tackle it, considering that you've probably had the disease? Do you still don all the equipment?
Of course. I mean, you have to bear in mind, I also tested negative. So, as we said before we started recording, this could have been the worst dose of man flu ever recorded. So, I could have just had influenza. I could have had another of any other viral illness. And so I think if I was positive, I would be more confident, but at the same time, I wouldn't not wear protective equipment. I think that would be bonkers. We don't know enough about this virus to know that once you've had it once and you've had a good antigen response or a good immune response to it, and you can measure that in your blood, we still don't truly know if that's enough for lifelong immunity or even 6 months immunity. It may be that, you can get it a second time. There are some case reports from China and elsewhere where confirmed cases have then had a second confirmed case in the same human being. So I think that there are too many unknowns with regard to the immune reaction and the way our body handles this virus, potential for viral mutation, so it changes from one form to another to further fox the immune system, that I think at the moment we just have to do the same thing for everybody, protect the patient, give them the best treatment and protect our healthcare professionals until we understand things much better, and that's what we're doing.
And of course, I guess what you were saying about someone contracting it twice, there's always the risk that the tests weren't correct in the first instance.
Of course. So, but I think, as you know, and as the media is telling us, there is, almost all research everywhere is focused upon trying to overcome this in a variety of different ways, whether it's treatment algorithms, whether it's diagnostic tests for carriage or that you've had it or that you're out the other side, clever new treatments. There's lots of clinical trial going on. The bottom line is this is a healthcare emergency, and we have to understand all of this. And it's not, we can't just understand one bit of it. We've got to understand all facets of it. And of course, as well, it's a moving target. I think that's why collaboration, and I think, we've seen some pretty incredible collaboration, certainly from physicians, from pharma companies. I think the two biggest pharma companies are working together to make a vaccine. This is the sort of way that we beat this, is by collaboration, scientific sharing, rapid publication of useful data, and working together literally on a global basis to make this better.
Absolutely. And one thing that we touched on before we started recording was the sort of knock-on effect on cardiac arrest and resuscitation as a general. Can you tell us a little bit more about that? Your thoughts on that?
Yeah, well, certainly, I'm going to talk about in hospital briefly, and then I'm going to sort of extrapolate to out of hospital cardiac arrest, where generally there will be lay people potentially doing CPR. In hospital side, the guidelines, as I sort of expressed earlier, are very clear that you do not start resuscitation, CPR, and resuscitating the patient who has had a cardiac arrest unless your team is in full protective gear, because the risk of, if that patient is positive, of you then getting a large viral load and becoming poorly is relatively high. That's a real step change to what we would normally do. What we would normally do if someone has a cardiac arrest on our ward, usually within seconds, one of the nurses would have obviously raised the alarm, will have put defibrillator pads on, started CPR. The team will be there instantly usually, and we'll do a resuscitation in line with the guidelines. You can only imagine that if you can't do that first bit and the CPR bit until you're ready to go, and putting on this equipment, as I'm sure people have seen on the television, it's not just a mask and a quick gloves. It takes at least, if you're going to, in an emergency, of course, you sort of speed up a bit, but it can take minutes before you get all of your equipment on safely, and that's got to be done by usually 4 members of your team. And so, that is a huge issue. The way in which we've tried to minimize the effect on the patient outcomes is that if we've got patients that we are genuinely worried on our cardiac ward are going to have a cardiac arrest, and of course that contributes quite a lot of our heart attack patients, then we put defibrillator pads on them in a proactive way. So they can be sitting on the ward, they can be talking to us, very happy with life, and they're recovering from their heart attack. But let's just say their heart function is not great and we're worried about them. Then certainly to have the defibrillator pads on and even connected to a defibrillator if we're very worried, means that if they do go into cardiac arrest with a VF arrest, we can just shock them back very, very quickly. And that's the thing, as you know, that saves lives. The CPR saves brain and heart function potentially while you're waiting for the defibrillator shock in VF or VT. So that's just one way, and that we didn't used to do, of course. And it's the same when a heart attack comes through the front door for us at the moment. We are assuming all patients have COVID-19, because we know that at least 15% of patients who get COVID-19 have no symptoms at all. And so we have to assume that everybody is COVID positive, because if we don't, we will get caught out. And likewise, on all of those heart attacks, we connect them to a defibrillator, put pads on. We would previously have never done that. We would only ever do that if we were really, really worried about that happening. And so there are real changes in the way we practice to try and make this as safe as we possibly can and to give the patients the best possible outcomes.
Mm-hmm. Necessity is the mother of all inventions, isn't it? And
absolutely.
Do you think this could see a long-term change in some practices? I know paramedic that attended to me told me when I interviewed him that he quite often attaches a defib to patients who are having a heart attack, just in case they have a...
Absolutely. Now, and I think the other thing, if you ask any senior nurse or experienced paramedic or anybody who's seen a lot of heart attacks, there's also this sort of experience that you look at someone. It sounds crazy, but you can look at someone and go, I've got a feeling you're going to have a funny arrhythmia. And very experienced paramedics and nurses are almost invariably right. There's just something about a patient's look. Sometimes, you can't even sometimes describe what it is about them that you worry about, but often your intuition, certainly of very experienced clinicians and nurses and healthcare professionals, paramedics, they will often tell you that this patient is going to have a cardiac arrest and a VT, VF or whatever, and they're very often right. But you can't write that down. Sometimes it's very difficult to document exactly what that looks like. It's just, an experience that you've seen patients that did this before.
Well, one of the reasons I wanted to talk to you is because we had a number of questions from people in the group,
Yep, great.
and as we're on topic with the COVID-19, we got a couple of questions around that. And the first one is, are we at risk from COVID complications due to having an ICD? And I'll just expand that as well. Just because we've got or had an event or have got a heart condition, are we at more risk?
So I think we need to be very, very careful to sort of individualize, especially for those people who are listening at home who, have some sort of condition. I think having an ICD per se, I'm not sure necessarily increases your risk at all if your heart function is completely normal. So let's say, for instance, you are an idiopathic patient who had a cardiac arrest for a source that we do not know, that you have absolutely no medical problems prior to that or after that. And what I mean by that is diabetes and high blood pressure, and your coronary arteries are okay, and you are otherwise a fit person. Then if your heart function is good, I don't think there's much evidence currently to suggest that that patient, just because they've got an ICD and had a previous cardiac arrest, is necessarily at any greater risk than anybody else of that age in the population without an ICD. I think the more challenging patients are those that have had a heart attack and then have an ICD, and that the heart function is not so good. And very often those patients who have a heart pump that is not as strong will also have diabetes, will also have hypertension, will often be a little older. And so, of course, that group of patients with less good heart function, high blood pressure, diabetes, and maybe a bit older definitely have a higher risk of having a bad bout, if you will, of COVID-19, as opposed to someone who doesn't have any of those problems. So I don't think ICD alone makes you at higher risk of problems. You have to, unfortunately, scratch under the surface to understand why you had your ICD in the first place, to work out whether the conventional risk factors for having more problems. And so if I just go through those briefly that we know at the moment, and these are not an exhaustive list, but just from the experience of Italy, America, and China, it would suggest that if you're male, you have a higher risk than if you're female. That if you have a increased BMI or increased weight or overweight, that gives you more problems. If you're diabetic, you might have more problems. If you have high blood pressure or cardiovascular risks, you may have more problems. And of course, if you're older, we know that the elderly are just less able to cope with the challenges this virus gives us. I would just say as well that I think that this virus does not just pick out old people with medical problems. And I think that is what probably scares a lot of us, particularly if you're in your mid-40s like I am. We are scared that we may well run into problems because we're not necessarily protected. So I think what scares the population at large is that, of course, a number of young people with no medical problems who are fit and well previously can run into severe problems with this virus. And look at our own Prime Minister. I wouldn't describe him as fit, but he's a 55-year-old male, as far as we are aware, with no other medical problems. But I would counteract that concern by saying to people, I think the patients that get into major problems are a small percentage of who get this virus, and that actually a lot of it is predetermined by our immune systems, which we do not understand how mine works differently to yours, works differently to the person down the road, and why do certain individuals have this really sizable inflammatory problem and then immune problem that really causes trouble in the lungs, that of course then requires intensive care and ventilation. And yet some people who have exactly the same, or maybe they're even older with more risks and problems, have literally no illness at all. And that is something we truly don't understand. So I think the reassuring thing to your group and the public at large is that actually there are huge swathes of the population who will get this virus and will not even know they've had it. There will be the vast majority of people who get this illness will have a self-limiting illness, just like I did. So you'll feel grotty and ill for often up to 12 to 14 days. It really does drag you out. But at the same time, you will recover. And then, unfortunately, there will be a small group of patients, and I think we have to be realistic, it is a small group of patients, who will then run into more serious problems of breathlessness and potentially require oxygen therapy on a ward, other medications, and potentially ventilation on an intensive care and organ support in the worst case scenario. But I think it's important to reassure everybody, both the population at large and your group, that that is a small group of patients. And it's not, just because you have a risk factor does not mean by any stretch of the imagination that you will automatically have a very bad illness. And I think that's important to tell people.
Okay, that's good to hear. One of the sort of common symptoms of COVID-19 is having a fever. And I've got a couple of questions around that. So someone's asking, will a fever, I mean, it doesn't have to be associated with COVID-19, but will having a fever increase my risk of having arrhythmias? And then on the other side is, can we do much beyond regular paracetamol to reduce that fever?
Yeah, it's a very, very good question. The bottom line is that in general, any illness, whether it be COVID-19 or whether it be sepsis, or, caused by a bacterial infection, or whatever illness any of us get, there is a likelihood that it puts the heart under a bit more strain and that it therefore makes an arrhythmia probably slightly more likely. But again, to reassure your listeners, I think the increased risk is modest. I think it's extremely modest. And so, before COVID-19, we wouldn't have thought about it too much. If you got a common cold or if you got a tooth infection that gave you a fever, you wouldn't really think about it too much. But I think that we've had a lot of time on our hands at home as well, and we've been inundated with information and stress and worry on the television 24/7. So I think if I'm going to answer your question honestly, I think that fever and any sort of illness is likely to very, very slightly increase the risk of an arrhythmia. But I do not think it's worth worrying about. I think it's a very, very modest and theoretical increase. In terms of if you get a fever, the advice from the community is pretty clear that paracetamol is safe. It's a good drug if you're able to take it, and if you take it in line with the recommended dosages. There is a suggestion from China and Italy that ibuprofen, which is Nurofen, which is a commonly used drug to reduce fever and muscle aches, and people often take it when they've got a viral illness, is probably not a good drug to take. There has been some evidence to support that when people have taken it in the early stages of the illness, that they have then developed a more severe illness at the sort of day 7 to 12, which we know is when the sort of worst part of the illness is. And so there have been some guidance both from UK authorities and world authorities to try and avoid ibuprofen if you can in someone who has COVID-19. So with regards to reduction of fever, you are pretty much limited to paracetamol.
Mm-hmm. Okay, sound advice there. And you sort of touched on this next question, really, which is someone's asking, how do you cope with CPVT and strong emotions around COVID-19? I mean, many of us are going to be anxious and stressed about potentially catching it, or members of our family potentially catching it. I don't really know that much about CPVT, but I guess this question really applies to anyone, but more so in cases where perhaps stress is a contributing factor to a disease or a condition?
Yes, I mean, I think I would generalize more, to be perfectly frank with you. And I think whenever we're talking on podcasts, it's best to generalize. I think that if you are pro-arrhythmogenic, then if you get a fever and get unwell, there is probably a very, very minuscule risk of increase of your arrhythmia, but I say a very, very small increase theoretically. I think that there is a lot of anxiety in the population at large, be those with cardiac problems, be those with no medical problems at all. I think that anxiety and concern is is across the board. But I think the key things to do are to educate people and are to reassure people and are to just ensure that everyone knows what they're looking out for. And I think the bottom line is I think the government's done a reasonable job at educating people, at making people stay home, making people not socially mix, keeping people essentially locked down to slow the spread of this and to protect everybody in general, but also, of course, it protects the more vulnerable people. I mean, I suppose one of the important things would be, I guess, if you are deemed to be an at-risk individual from some of the risks that we talked about, so age, other medical problems, diabetes, hypertension, then I know that there is suggested advice that you have a 12-week isolation in essence, and that you get food dropped to you, and that you essentially look after yourself at home for that period of time without mixing socially. I guess it's whether you are fitting into that category or whether you are fitting into a category that can, go out and get your own shopping, go out and, do things and take a little bit of exercise in line with the guidance. And I guess that could cause a little bit of stress and anxiety about exactly which group people fit into, possibly. But I think anxiety and concern is uniform across the UK. And I think that when we are allowed to mix a bit more, I think that we're going to end up with a fairly anxious society that will require quite a lot of support to get us back to, happy, high quality living again. Because I think this will really, really take a lot of effort to get back to where we want to be.
Absolutely. I mean, regarding sort of anxiety and stress, I guess people should be looking to do things that can reduce those, like mindfulness or just low energy things like Pilates and yoga and Tai Chi, and just sort of taking themselves away from the points of stress. Like, don't look at the news all the time because,
I think that's exactly right. And don't look at the death rates every day. Don't get obsessed by the number of admissions to hospital that, a poor healthcare worker has died. If you look, and this is going to be slightly controversial, don't get me wrong, healthcare workers are at a higher risk, in my opinion, because we are exposed to the sickest patients who probably have the most virulent virus and the most viral load, i.e. the biggest dose, because they're the most sick. However, we know that this virus is common. We know that this virus also affects and sadly takes the lives of many young people who are not healthcare workers. And so I think, again, in the passage of time, we need to look at exactly how many healthcare workers, if you like, we would have expected to have died, and actually how many do. Now, don't get me wrong, every death of any of these patients, healthcare workers or not, is truly tragic. But I think we don't understand fully, if you like, the risk of being a healthcare worker yet. The Italy experience would suggest it is higher, as would the Chinese experience, and that protection of all of us is of paramount importance. I think there is no doubt about that. The other thing I would say, and a number of my friends have done this, I'm very lucky. I have a job where I'm continuing to go to work. I'm continuing to work with a team, which is amazing and fulfills us every day by having friends and colleagues around us. And we're allowed to do it, and I'm not going to lose my wage. Now, I can't imagine if I was a business owner or self-employed where literally my income has gone to zero overnight. I cannot quite imagine the stresses that would have. So I think that must be a huge stress. The financial pressures that then will come from that over the coming weeks and months must be terrible. And somehow we need to take some positive things from this and try and keep ourselves sane. And as you have said, a number of my friends have taken up exercise. If we're lucky enough to have a garden, there's a whole host of exercises you can do in your garden. Use it as a time, because a lot of people have got a lot of time at the moment. Use it to learn a new skill, a new language, some art, something that you are allowed and can do, and that maybe you've never ever had the time to do ever before. But in this rather challenging time, all of a sudden you do have time because of the very nature of what we're being asked to do. So I think somehow we need to take a positive out of this, give ourselves and our lives some focus, so that when you come out of COVID-19 and the world does go back to normal or post COVID-19 normal, then maybe you have some language skills, maybe you have some art skills, maybe you're fitter, maybe you've you've got rid of your diabetes because you've lost a couple of stone of weight. I think somehow we have to take a health and mental improvement over this time to try and keep us all sane and come out the other side.
Absolutely, yeah, that's some very wise words there. I mean, it struck me, and my wife blogged about it just recently, that there are many parallels between this situation and what a cardiac arrest survivor and their family sort of goes through, really. And this period is a great time for us, like you've just said, to reflect on our own selves and work on ourselves, because I know many COVID-19 survivors are going to have to do very much the same sort of things in the coming weeks and months.
I think that's right, and of course as well, many of the worst affected survivors will have had a protracted intensive care stay, very similar to many of your listeners. So we know that if you go onto a ventilator in hospital with COVID-19, you tend to stay on one for anything between 7 and 10 days. Of course, the shorter the time on a ventilator, more likely you'll come out and do better more quickly. But yeah, this is a very significant inflammatory process, and certainly you do not intubate people quickly and get them off the ventilator quickly. It is a protracted intensive care stay. Not only that, I think the worst thing about COVID-19 is the lack of information for family members. Now, as you know, when you have a cardiac arrest and you are asleep on intensive care, often for the first few days, your family can generally be with you as much as they want in the pre-COVID-19 era. And we're very flexible with, historically with visiting, and you can spend as much time, you can phone whenever you like. We really do try and look after the family's well-being as best we can. If you contrast that with the current situation where you have a COVID-19 patient on an intensive care who does not get allowed to see anybody ever, unless they're essentially dying and that it's their last few hours on the planet, that is for me an incredibly scary time, both for the patient if you're awake or if you're pseudo-conscious or semi-conscious, but it's truly awful for the family who are sitting at home, often waiting for a call at the end of the day or the end of the consultant shift to tell them how your loved one is once every 24 hours. So I think there are contrasting and different. There are similarities, and I think there are also differences. But at the same time, I think both have very challenging psychological aspects, which, I agree with you. For the foreseeable months and years, we're going to have to deal with and improve our services for those patients and families.
Mm-hmm. Like we are trying to do for the cardiac arrest survivors. Maybe I need to start up a Facebook group for COVID-19 survivors as well. And you and Boris can join.
Yeah, but I don't think I'd be allowed in, because if I went for the world record of COVID-19, I wouldn't be allowed in because I tested negative, didn't I? So
that's true.
I'm a man flu support group. I think it is important to be reassuring to our groups, actually, because with all due respect, if you're going to get it and you're going to get it bad, you're going to get it bad. But the chances of that happening is very, very small. Does that make sense? Mm-hmm. We have to put it into context.
Well, that's been an absolutely fantastic journey into your life of having COVID-19, and also how patients and heart patients should react and how we can understand it a little bit more. And I think you've certainly put our minds at rest as well, as much as we can. So thank you very much for that, Tom, and hope to speak to you again soon.
No, my pleasure. And everybody, please take care, stay safe and keep yourself to yourself.
This concludes this episode of the Life After Cardiac Arrest podcast, and I'd love to know what you think. And you can do that via Facebook, Twitter, Instagram, or the website southerncardiacarrestuk.org. And you can find us by Googling Southern Cardiac Arrest UK or the Life After Cardiac Arrest podcast. If you have found value in this or other episodes, please help spread the word by leaving a review on your podcast provider, such as Apple, or wherever is convenient. And don't forget, if you want to know more about life after cardiac arrest, check out our books, Life After Cardiac Arrest, on Amazon. Make sure you click subscribe, and I'll speak to you next time.